Matthew Olson on THCV Spotlight, and I'm here with Stephanie Strong, who is one of my heroes in the current iteration of digital health. And we met up last week. I think it was the first time in person last week, Stephanie, although we've been communicating for, you think you've been in health too, but way back in the day when you had a real job as a venture capitalist before you became one of these crazy startup CEOs. All right. Stephanie is the CEO of Boulder. Boulder is one of the leading players in the substance use disorder / addiction treatment space, and we'll talk a lot more about that in a second. But and then the other reason we're doing this interview is that we both have our moments with the DEA, the Drug Enforcement Agency, and Stephanie's had more than a moment with them in recent months, and we're going to talk about that a little bit as well. So, Stephanie, before we start there, I was kidding, but you were a sort of famous rich venture capitalist who decided to do a startup. This is, as I explained to you at the time, this is the wrong way around. Most people who succeed in a startup and then go and retreat to the calm backwaters of venture capital. So what happened to you?
Yes, well, we talked about this. You gave me the advice too late. Once I'd already jumped ship, you said that was a ridiculous thing to do. And it has been a long but truly meaningful 7 years since then. When I was in venture, I had the privilege of really seeing so many smart entrepreneurs building things in this highly regulated but very deeply fulfilling space of healthcare services and technology. And I saw specifically some of the challenges of addiction treatment under the status quo, working with a platform of outpatient centers that were delivering care for opioids and alcohol use disorders, and so many opportunities to improve the model and the way that it was delivered to be more accessible to patients, and the way it's financed to align incentives around good quality outcomes.
So basically, you thought you wanted to go and do some operations because you were drawn to that particular area. Why pick? Before I start with the bottle, but why pick this substance use disorder? Look, obviously it's a massive problem, and I was in a session I think you weren't in at Salome's behavioral health conference last week, where someone iterated they went from like 10,000 deaths for opioid addiction to over 120,000 this year. Whole bunch of stories behind that, but what I mean, obviously it's a whole area, but so much other stuff in healthcare to look at. Why did you pick that one?
I was able to see a lot of different spaces, palliative care, oncology, women's health, and there are great models being built across all of them. But actually, addiction treatment is some of the most transformational medicine I've ever witnessed being practiced. When you see patients coming in incredibly sick, in withdrawal, often have lost a lot of their social supports, maybe their housing, and are incredibly vulnerable. And in this place where they're getting care, where they're treated with dignity and empowered, told that they matter, and given very evidence-based medicine that should be widely available. It's affordable medications that we've had on market for decades with just so little utilization. So seeing people get well and transform physically in a matter of hours after taking medication, and their lives in a matter of weeks or months, the longer they're getting supports and able to be set up for success, it changed the way I think about medicine and the healing and transformational power of good care for a population that is so vulnerable and trodden on. And at the time in 2014, I was constantly, like all of us in America, reading about the opioid crisis and only hearing stories of despair. You would never know that there are proven treatment options. There's a lack of awareness and education. There needs to be more advocacy for people who deserve to get this treatment. And there are a lot of barriers that are structural we can overcome with technology and innovation. So it put together a lot of some of the most important things that make me passionate about healthcare innovation. And it has lived up to all of that and more. It is one of the hardest areas of medicine to practice. It is more heavily regulated than most. There's a lot of stigma and misperception, a lot of change that needs to happen in the payment landscape. But when you are able to do that for even one individual and they say, you saved my life, I have my 8-month-old daughter back, it is so worth it.
You said a lot of things there, which are obviously part of what Boulder does. But now let's dive in. So I am somebody who has, an addiction with opioids or alcohol, or other substance, or whatever. I have a problem. What has been the traditional solution, and what do you guys do?
It's a great question. And addiction impacts people across all walks of life, all demographics, ages, locations. But Boulder is very focused on Medicaid beneficiaries and bringing care to those who are low income and often have a lot of social needs, in addition to particular access challenges for finding medical care. So in the traditional system, a typical person may call around looking for weeks to get into an outpatient facility, where they're then asked to commute. For people who live in rural areas or really most parts of the country where there aren't prescribing clinicians able and willing to do this type of medicine, they may have to get a ride and make it to a clinic weekly or even daily. And that's on top of mandatory requirements around counseling or group sessions. They may have to also go see a parole officer, go to the pharmacy to get their medications. We added this up at one point. It's over 100 in-person encounters in the first year of treatment alone. And this is for a chronic condition where the longer you're in care, the better you do. So instead of constantly asking people to keep coming to the care, we envision telemedicine as an experience where people can privately, without stigma, and conveniently from anywhere they are, access services that are personalized to them. So in that tight window of readiness where someone reaches out a hand for help, we're able to pull them in and get them in to see a clinician, often that same day, and then stay with them throughout their journey. And whereas in traditional treatment, when someone is struggling, we may add more barriers, mandatory visits, ramping up the amount of time you have to spend with a clinician, shortening the window with which you get prescriptions so they can tighten controls. At Boulder and through telemedicine, we're able to ramp up services without burdening the individual. So that may mean being able to see them before work in the morning at 7 a.m., or adding a peer recovery specialist to their care who connects with them with their own lived experience and sharing stories about what anxieties or hardships they're facing. So it makes an interdisciplinary model and a really comprehensive and long-term model possible for people in ways that brick and mortar hasn't been able to.
So how do people tend to find you? I mean, there's a couple of routes, right? One is maybe referral from the standard healthcare system into whatever type of substance use disorder treatment programs there are. But also, yep, you mentioned parole officers. There's obviously the criminal justice system, which a lot of these people by definition going to end up with. So, and it may be, and the other thing we know about addictions, a lot of people under addiction don't really want to stop being addicted. Maybe some there. So how do people find you at Boulder? And then when you do that sort of entry point, what other layer of services? You mentioned some of them, but what would the typical experience of an individual coming onto your system be?
It's a great question. And I like to also just distinguish between people wanting to continue using drugs and people wanting to be addicted, because I think there's a nuance there that is important for all of us who are trying to understand how to better serve folks and understand their decision making. There are people who are using drugs and it's not actually impacting their life, like eating a lot of ice cream you mentioned earlier, may not be healthy, but it may not be life-threatening. There are people who are using cannabis or drinking coffee or smoking cigarettes, and varying degrees of harm. And for those who are addicted or meet the criteria for a substance use disorder, that's distinguished by being continued compulsive use despite unwanted consequences. So by definition, not wanting to use anymore. Now, that doesn't mean they necessarily want to get treatment. When we look at what treatment is in America, it's often a methadone facility where you're lining up like cattle at 5 a.m. Mandatorily to get your medication every single day. Or it's a program that is faith-based and requires you to accept religious beliefs that may not be part of your identity. There are a lot of reasons that people don't want to get treatment today. And so Boulder is looking to tackle that, I guess, easier problem. We don't have to convince people to get help that they don't want. There are millions of people who really do want help and just want it in a way that's evidence-based and meets them where they are. And when we look at the system today, you asked about how people find us and referral partners. I think that's such an important insight that there is this whole ecosystem. And as a telehealth provider, sometimes we see folks who are saying, I can just get the patient to enroll directly online. They can Google search and find us. We don't need anyone else involved. And that's true. That's a really good pathway. But at Boulder, we've tried to be more intentional in our thinking about finding people who are in different parts of the system of chaos that exists today, this really fragmented ecosystem. And we can play a role in adding value, not just for patients, but for all of the others who are impacted by this disease and the lack of treatment. So we see people today who are just cycling through from overdosing, going to the emergency room, being discharged, maybe going to a temporary detox facility where they're not getting long-term care, and then back into the drug using community, incarcerated for a while, very fragile when they're discharged to get another overdose, and just the cycle begins. And it's costing the carceral system and taxpayers, it's costing the healthcare system, and certainly for those patients and their loved ones who are grieving. It's really a pretty dire status quo. But at Boulder, what we've aimed to do is reach all of those stakeholders, the hospitals, the EDs, the jails, and the community folks themselves who are telling people about Boulder after they have a great experience with us, which is actually our number one referral source, is existing patients. So we're making very easy on-ramps from the healthcare system and the community, and then that's being reinforced when people have good experience with us and telling their loved ones about Boulder.
So what's it like when they start? So I get referred somehow, I get a number, I call in. What happens next, and what are the layer of services that a typical patient would get?
It's a great question as we think about what is different for each of our patients. So let's say someone finds us through a discharge manager at the emergency department. Rather than being sent home with no links to long-term care, we can coordinate on-site with that planner and the patient, get them logged into the app, started on a medication prescription if it's appropriate for them, which they can pick up that same day, assign a peer recovery specialist to get to know them and help set goals around many of the other non-clinical things in their life. Our patients say they want to find a new job or regain custody of their kids, spend more time with them on the weekends, whatever's motivating them to make that change and making that a consistent part of their care plan. And then patients can get all of their medication and ongoing clinical care through video visits, text messaging, other content and resources through our app. And for other patients, they may be going through other healthcare challenges as well. So maybe they find us online, but we learn that they're pregnant and ask to coordinate with their OBGYN so that we can have a prenatal plan that incorporates addiction treatment and all of the other prenatal care, and ensure they have an advocate when they deliver who keeps them from experiencing some of the stigmas that we know pregnant women experience when they're having a history of opioid use disorder. So these are just some of the ways that telehealth can bridge across the healthcare ecosystem and the ways that we can personalize care to meet the needs of our patients that have a really major impact on their total health.
Absolutely. And so let's touch on the prescription part, because we'll get into that when we discuss the DEA. Suboxone is the drug most people are familiar with, which is like well, for those dummies like me who've heard of it, don't know what it does. Describe, what is it? How do you use it and prescribe it, and who is it appropriate for amongst the patients coming to you?
I think you're right, Matt. The people who are hearing Suboxone for the first time, it's always interesting to me, because I think if cancer was the number one public health crisis of our time, and there was a drug that reduced the death rate by 60% and was incredibly affordable, we'd all know about it. But with addiction, there's still a lot of misinformation about what quality care looks like, and some stigma about prescribing medications for a drug addiction. So we still experience that, but the evidence is truly unassailable. The safety and efficacy of Suboxone or Buprenorphine and other medications for addiction like methadone, there are so many compelling studies that show it keeps people safe. It stops any type of withdrawal or craving symptoms that can be overwhelming and excruciating for people when they try to stop. And it lets us then add many other supports and resources for people who want them to make other changes once they're stabilized and don't have to be thinking about using opioids all the time and constantly trying to find another way to meet that need. So Suboxone is the mainstay of Boulder's program, as it is recommended to be for any treatment modality for opioid use disorder, whether in person or through telemedicine. But it's very difficult to prescribe given the regulatory and administrative barriers, a lot of compliance, and again, stigmas, as well as low reimbursement historically. And all of these things collectively have caused a dearth of addiction treatment providers And the federal government for decades has been trying to educate clinicians and trying to get primary care to adopt buprenorphine prescribing. But not only have we not seen an increase in capacity, we've actually seen a decline. So it is a really severe access issue. And we at Boulder are very focused on making prescribing buprenorphine and doing holistic care much easier for the clinician than it has been historically.
And on the pure technical matter, I mean, there's a lot of problem. It's a controlled substance, right? And there's a lot of problems prescribing a controlled substance. I mean, you have to get more frequent renewals of prescriptions. It doesn't get carried. You can't move the prescription around. There's a bunch of. I know this from just the Adderall stuff that I get for my kids. So, how easy is it so if I become a patient, how easy we find out, the local CVS? Will they give it to me? How easy is the process for me getting it once you prescribed it? How does Boulder work in that area?
An important point. As hard as it is for patients to find a prescriber and find one who's taking patients who are pregnant or have an open legal case or on Medicaid, even when a patient gets to that point and they have a prescription in hand, they have to navigate the pharmacy system. We have heard over the last several years during the pandemic, as everyone has been getting telemedicine care, that pharmacies are refusing to fill telemedicine prescriptions for various reasons. And even prior to telemedicine, the pharmacies are able to deny filling a prescription for a patient on almost any grounds. That could happen for contraception. It can happen for patients who are seeking gender-affirming care. And unfortunately, that can be a really difficult experience for someone who's taken this brave step to try to get help and just be told, we don't take Suboxone patients here. We don't carry that, or we don't want to help you.
Do you have a sort of a network or informal network or knowledge base of where a patient in a particular location can go find it? I assume it's not supplyable via delivery, so I assume you have to go to a physical place to get it. But I mean, is that something you can actually help with?
We do, and in fact, it's become, rather unfortunately, one of the more impactful things that we do for people as more and more pharmacies.
This is part of your moat. You actually know where someone can get the stuff that works. Yeah.
Unfortunately,
yeah. Okay.
And especially in Ohio. So we're in several markets, and Ohio is a big state, a lot of rural areas, and we have hundreds of patients who tell us that they've tried to go to a pharmacy and aren't able to get their prescription. Occasionally, it's a pharmacist doing their job and having some due diligence over why a patient is getting a prescription from a provider who lives far away. And we'll give them a call and have our physicians talk about the patient case. Hey, we've been seeing this person for 2 years. We know them incredibly well. We know their dogs' names, and they are getting their medication that they need. They can't get it in their hometown because there's no prescribers there. But sometimes we just have continued barriers. And as you can imagine, it's very difficult to be calling pharmacies all over the state all of the time for people who are waiting at the pharmacy to get their prescription in the middle of a 1 hour break between their long work shifts. So it's a hardship on everyone, and it's only gotten worse. And I fear it will get worse before it gets better, because there's a lot of unclear guidance about telemedicine and a lot of conservatism being practiced by the big chain pharmacies in particular.
Absolutely. And just to clarify, the drug itself it's a controlled substance, but it's not actually an addictive drug that can get you high itself, right?
Correct. Yeah, there's no euphoria experience with buprenorphine. It's got a remarkable safety profile, has been FDA approved for a very long time, and it is compared to the absolute lethal illicit supply that patients will use as an alternative. So going out to take fentanyl on the street versus getting buprenorphine, the public health risk is astronomical.
But buprenorphine is it's a replacement. The impact it gives you means you don't want to take the opiate, right? So it's and then how long do people tend to stay on it before they can sort of trail off and be have their addiction problem solved or cured or whatever? What's the general profile?
It's a very personal decision between a patient and their practitioner. But if you look at the population health data, generally the longer someone is on medication, the better they do. And for some people, that could be lifelong. We recommend at least 12 to 18 months and a relatively stable kind of social and functional setting for a patient before they try tapering. a lot of patients actually have motivations for tapering that are unrelated to the way they're feeling or the way that they're doing. They're just worried about having to fight so hard to get access to this medication, the barriers of seeing a clinician, trying to find a prescription, and the stigma that they hear from maybe loved ones or folks at their NA meetings cause them to make a decision that may actually be harmful for their health and not be ultimately what they really want. So we work with patients to understand what they're looking to achieve and how buprenorphine is impacting their health, their happiness, and any side effects, which are typically pretty few and far between, and help them make those decisions. Most Boulder patients are in our care, whether they are taking medication or not, for years, and that is a tremendous benefit of telehealth that we've been able to publish on and add to the literature in impactful ways.
So before we get into the EA, just a couple of stats about Boulder. So how many patients do you have roughly? And I mean, I'm not saying how many are you treating today, but ballpark, how many patients are you treating at the moment?
So about 10,000 patients across 3 states, and
Which states are those?
Oregon, Washington, and Ohio.
Okay.
And opening new markets now. So 2024 will be in twice as many locations.
And I just assume that getting to a new state is not like, oh, let's just, let people call it from here. There's some complications with that, I'm sure, right?
Not for us. Telehealth certainly does make it much easier to plant a flag in a new market and hang a shingle, if you will. But what we like to do as part of our model is integrate into the community and plant deep roots, and to be contracted with every major health plan so that care can be affordable. It takes us about 90 days to go in and work with every Medicaid and commercial health plan in a region. We've done it now with over 100 health plans, and have phenomenal partners who help us make care free to patients.
So why is it only 3 states so far and not 50 or 45 in that case?
We want to be really good at what we do and prove the model before scaling too quickly. We learned some lessons over the last few years about what can happen to quality, and coming from venture investing lens, recognizing that there's a real responsibility in scaling a business like ours. So we wanted to get it right. And I think what we can say about our outcomes is that they're unmatched. We have retention 3 times higher than the industry benchmark. We reduce total cost of care by 70+% for our health plan partners, and 90% of our patients are covered by Medicaid. So we're meeting a lot of social needs for them as well. And now feel very ready to bring this into new markets with the model that is also very focused on collaboration across the full continuum of care. So we have a dedicated team of community engagement specialists who are familiar with the locations where we're practicing, actually have physical presence in these communities, and do outreach to make sure that we're listening and learning about how we can plug in to whatever folks are already doing some work for these individuals on the ground.
Right. And there was an article in the Washington Post or New York Times about that from you. I can't remember. It was it's just, and it's what you just said sounds easy, but it's really hard. I mean, setting stuff up on the ground, and not always been the case that telehealth systems have done that, or even that systems actually in physical locations have got that kind of community outreach, and something that we're clearly missing across the board in American healthcare. And with folks with this kind of addiction problem or substance use disorder, it's clearly a big issue. Now let's go into the pandemic. So before the pandemic, there were certain laws about prescribing different types of drugs, and there was this called the Ryan-Haidt Act around controlled substance, and then that changed in the pandemic. So can you just start off and explain what was the law in 2019 and what happened in 2020, and then we'll discuss what happened next.
Absolutely. In 2019 and in the years leading up to it, there was a national priority to make medications like buprenorphine available without an in-person visit. But year after year, the kind of promised reform didn't materialize. It was only during the pandemic when telehealth flexibilities were extended in a blanket manner across the country, and no in-person visit was required to prescribe.
So before the pandemic, what did a Boulder patient have to do? I don't know how many patients you had back then because you were earlier in your stage. What did they have to do to get access to the medication?
So we were founded in 2017, before there was any pandemic, and we integrated with primarily FQHCs, or federally qualified health centers, and worked with primary care clinicians who were appreciative of our services, the ability to wrap around and help support many of the challenges that people were facing in getting behavioral health care or finding housing. But we weren't able to do the prescribing initially. And that was what all of the primary care staff who were overwhelmed in their communities wanted us to do. And we were ready when COVID first hit. It was actually in one of our markets in Washington, and one of our health plan partners, Blue Cross, called and said, we need you to be everywhere immediately. And we stepped up and provided care for hundreds of people in 2020. I'll never forget, just learning about the pandemic and finding that we now had an opportunity of staff full of clinicians with addiction medicine training who were taking calls from patients who said, my house just burned down. I'm in Southern Oregon. I've got no belongings. My pharmacy is closed and I'm going into withdrawal. I need help. And being able to offer them medication with no barriers. And since then, we've seen this happen thousands of times, people getting care without the needless inconvenience and inaccessibility that the system has imposed on them, until this major change happened that opened all of our eyes to the promise of telemedicine.
So now we're in a state where you can now prescribe without having to have a physical presence. You're doing that every day. And then the public health emergency is about to end. And what happened next?
Yes, we were all preparing for the end of the public health emergency. It's another answer to your question. Why only 3 markets when there are millions of people growing every year who need your services? And we wanted to make sure that we would be compliant and wouldn't have any disruption to care, as we've seen some of our colleagues have to experience in states that have already made restrictive changes. And we learned in February that the DEA had proposed a rule that would reinstate an in-person visit. We were all surprised in the industry because the data, including studies coming from the NIH and CDC, were so clear that there was no increase in misuse of these drugs during the pandemic. There was an increase to retention and access, and that the need for a worsening opioid crisis was only growing. Still, when that happened, the first thing that we did when the news came out on Friday was let our patients know, hey, the DEA has proposed a rule. It's not final, but we want to make sure that you're ready and won't have any disruption to your care. And we learned from our patients who flooded us with their stories and anecdotes that, I don't have a primary care provider. I have no transportation, no driver's license. There's no way I'm going to be able to get an in-person visit. Why would they take this away? I'm doing so well. And we were feeling the same in our care team, just so perplexed as to why we would take one of the only tools that's providing hope in the middle of a public health emergency. So after that, we really rallied to advocate to prevent this change from occurring.
So round about that point, I started noticing that you personally and Boulder were very active on LinkedIn and other channels, and I even I think stole some of your stuff, and I personally added some comments to the DA. They had a comment period, right, for this.
Right.
And you had a website with comments from your patients, and I don't know how many of them commented. And obviously you really flew the flag for your entire industry in this. What did you and Boulder do in terms of connecting with the DEA and connecting with the station? Where are they as an organization? They have not exactly been known as one that has been, how should we say this, thoughtful and scientific about some of the processes they've carried out. I frequently said it's been much easier for them to go after a primary care doctor who they think is prescribing too many OxyContins compared to tracking down a Colombian drug cartel, and they have for decades not been at the forefront of certainly harm reduction. So what happened, and what was your connection with the DEA, and what happened with the process?
It's a super challenging dynamic when you have an agency that's responsible for policing and law enforcement and not really public health, finding itself in this oversight role for legitimate providers, and now even more complicated in telemedicine and thinking about state-by-state regulations and how they roll up to the federal level. So it unfortunately, like all regulatory complexity, harms the people who are the least able to recover from that kind of blow. And we saw that our patients were in a really vulnerable position, but knew that collectively we had an opportunity to change this process. We're in a a democratic country, and we should be able to influence change. And that's what we were very, very motivated to do. And what happened during the public comment period was Boulder and our peers really harnessed the power of patient advocacy in ways that I think provide a lesson for all of us as digital health innovators to organize and advocate as a collective. So our patients, I mean, we got over 15,000 comments, and we directed them toward the DEA in the public record. We worked with state senators and elected representatives from multiple states across the U.S. and started a text campaign so that everyone in our broader network could also access legislative bodies wherever they lived. We did some fantastic work with some of our advisors, including the former CMO of U.S. Medicaid and other just influential people who were able to amplify some of the voices of our patients that don't typically get to be heard. And there were over 40,000 comments left for the public record that often, we were, cited as the provider. And this changed the law. The DEA responded saying that this public outcry was a reason to press pause. And they held some listening sessions in September where our medical director was able to speak and engage directly with the DEA administrator, who was very thoughtful and engaging with other physicians and asking questions, signaling that there's going to be a change to the proposed rule. And we hope one that will be much more flexible and evidence-based for the people who need this care so desperately.
Well, can I just say fantastically well done, because, I know it's in your business interest, but, just speaking to you, listening to you talking from the heart, this is, in the interest of patients. And there are so many places within healthcare and within society and within, criminal justice where we're doing stuff that is just there because it's been done for years and years and years. If you go back and look at the history of where the DEA started and the legislation we've had around, going back to heroin in the previous century and opiates in the previous century and marijuana the century before last, and marijuana in the previous century, and the drug war and the rest of it. Some stuff has just gone on that it's been so crazy, but we've been unable to stop. And here in this little tiny area, you led the forces of light against against something which would have been, would have hurt a lot of people. So you're my hero for doing that.
All the credit goes to our patients. And I think we were the only provider testifying in front of the DEA who directly read from quotes that they sent us and made sure that their voices were heard. And there's therapeutic benefit to that. I think when people with medical conditions are able to advocate for themselves and their care, it makes them healthier. And we saw an uptick in patient retention and engagement during the period of the DEA battle. Same with our care teams. People who are doing this work purely out of mission, and it's very challenging work. Being able to, see that these policies that have been so gray and nebulous can be influenced, that their work really matters, not just in the individuals they're treating, but in creating system level change by being an example of what quality care can look like in the modern era. So I think it's a really great story. We're still writing it, but this, this about face from the federal government in response to digital providers and those who are practicing this medicine and their patients coming out to talk about what it means to them. I think it's a great example of how, digital health can do good. And though we're all small in the grand scheme of this massive system, we can affect change.
Fantastic. I've been talking with Stephanie Strong. She's the CEO of Boulder, which is, as you've been hearing, a leader in many ways in the treatment of substance use disorder. And Stephanie, thanks for all your work. Thanks for coming and talking with me, and really, really appreciate everything you've been doing. And good luck, because you are fighting, not a Christian, but you're fighting the Lord's fight here. And you've chosen it wasn't the easy money path you chose, right? It was you're young, but this is a long sustained battle you're going to be fighting for many years. So, just good luck in that.
Not easy, but worth it every day. And I'm so grateful to do it. I'm also so grateful to share more about it. So thank you so much for your ongoing support, Matt.